Ladies and gentlemen, a very welcome at the launch of the Master Population Health Management. We are here with quite a mixed audience. We have, of course, bachelor and master students interested in master programs. We have PhD students and colleagues from the LUMC. We have healthcare workers, we have managers and policy administrators, all from Leiden, The Hague, and other parts of the Netherlands, and of course also from abroad. And that's great, since this is exactly the audience for the Master Population Health Management. The new master we will introduce this afternoon, and therefore we will celebrate the launch. We have an excellent program, and I will be the host. I'm Jet Bussemaker. I'm professor at Leiden University Medical Center and Leiden University on policy, science, and societal impact, especially in healthcare. All aspects that also will return in a master. And I hope to share as a teacher in a master also my own experience from former jobs as being a Minister of Science and Education, also being a Deputy Minister of Healthcare, and with my current jobs, such as the President of the Council of Healthcare and Society, and not in the last place, as the chair of the movement Healthy and Happy The Hague, in which we try to improve health in disadvantaged neighborhoods. So in the coming 1.5 hours, we will have a line of excellent speakers that will give you more details about the why, how, and what of the master program, from macro international policymaking level to the micro level of the doctor-patient relation. And with this launching event, we hope to make you as excited about the program as we are. We have people from the Leiden University Medical Center and the campus, The Hague, all being involved from the beginning. And we also have 2 external guests. A special welcome to Jan Kimpen, Chief Medical Officer at Philips, and to Ronne Maruo, Specialist Internal Medicine at Haga Hospital in The Hague. You will meet them later on during this meeting. During the program, there are opportunities to ask questions to the speakers. To do so, and I would really invite you to be active in the program. To do so, please use the hand-raising function in Zoom, and I will give some of you the floor. I also want to tell you that the event will be recorded and used for communication purposes. If you do not wish to come into view, please turn off your camera. But of course, we really like an active group of an active audience. So be very welcome to have your camera on. And I hope you will experience an interesting afternoon. Hopefully, this may stimulate potential students to join this program and to tell the story about the master and to share it with others. Okay, let's start with the first guest. And I would like to invite, and he's already here, Professor Dr. Pankras Hogendoorn. So, Pankras Hogendoorn, you are the Dean of the Leiden University Medical School and one of the initiators. So, congratulations with the launch of the Master, because I know you have been working on it, thinking of it for a very long time. So maybe you can share your experiences and your opinions about the aims of the Population Health Master. Why did you want to start this as a strategic aim from the Leiden University Medical Center, among all other possible tracks to organize?
Well, I think first the demands and questions from society with regard to health have been changing over the past decades. And while, let's say, 20 years ago, we were focused as academic centers in solving difficult questions of rare diseases, we now realize that the real questions are in the population. And in order to avoid the meltdown of the medical institutes as a result of the ongoing demands of society, you need to be earlier, not waiting till patients are ill, but to go into society, to look for prevention, to understand the population, where it starts before it comes to the hospital. And also afterwards, the successes of medicine also made that people are now chronically ill, which of course have an impact in society, what's going on. So the demands from society to healthcare have been changed enormously, which makes that the university medical centers need to change. We are not only here for healthcare, but also for health of the society. And therefore also the education programs need to change. When I studied medicine, it was very important to exactly know the mechanisms of disease. Now you have to know the mechanisms of society and disease. What's going on there? How can we influence
Yeah.
health of the society? I think that's very, very important.
It's interesting that you start talking about an educational program and not about a research program, although we know that they are both very much interrelated. We both have an history in the Dutch national science agenda, and I know you are very involved in it, but you did not start with research, or is it a combination?
I think it's love and marriage, horse and carriage. You can't have one without the other. I think it's very important when you want to bring education, you also have to bring research. And as a result of this research, new insights will come into the educational program. So they are very much interconnected. And that's also that you, for that type of research, you need new skill sets which are not naturally there with medical doctors. So you do need to go into to think about policy making, to go into data science and things like that, which are very much important to when you want to understand the population where you want to um, investigate and do interventions.
And is there for you an argument why this master is a master at Leiden University Medical Center, or could it be everywhere?
Well, I think a number of important things. So we are, amongst others, based in The Hague, which is a typical large city with enormous differences in population and large populations of new Dutch people coming in with their own background and their own attitude. So
that's, by the way, one of the things I discover as well as chair of the movement of Happy and Healthy here at The Hague, and the populations being involved.
So in this strategy of building this new master, that was also built upon the strategy of going to The Hague, to a large city with all the problems of large cities in here. And next to that large city, of course, it's of interest, and I'm making a link with the international people. Of course, it's interesting to see how this interrelates with other communities around the world. So the population health questions in The Hague in the Netherlands, they are different in India, they are different in Africa, they are different in Indonesia, for instance. And what can we learn there from that population? Amongst others, in the COVID pandemic, we know the immune response in Africa is completely different than here in the Netherlands. Why? What's going on there? So that's why it's so important to be international. And coming back to your question, I think Leiden always had a outreach to international populations. So that's why this is also very much to our heart.
Is a more diverse population also in cities like The Hague. I think we can also learn a lot from what has been going on in other countries like India and Africa and so on. So it's an interrelated process of knowledge exchange. Okay, so when are you satisfied, let's say in 5 years, about what the master population health management should bring?
So when you start a new master program, that's always first an uphill battle. And I'm satisfied that more people see that this is the way to go for healthcare in the future, not only here in this educational program and science program, but also as an approach towards society. So that's a high overview type of goal. I'm satisfied when this body of knowledge is also present in daily healthcare and also the organization of healthcare and the organization is sitting. So this body of knowledge that needs to be marinated throughout society. This is an important goal. And when you don't have an educational program, then people have to find it out themselves. And I hope that we will create ambassadors, not only for the Netherlands, but international, for this kind of approach towards healthcare.
So there is an important role for the educational director of the master, but Mark Bruinsels, and we will talk with him shortly, but also for you as the Dean of the Leiden University Medical Center to bring the knowledge also and the students with the master degree to the university itself and to the hospital to share their knowledge with other professionals in the hospital.
So that's exactly. So this is a type of knowledge you want to bring to a medical center with multiple disciplines together, which is very important. So not only the classical medical background, but that's one of the reasons we teach this also in The Hague, because the Faculty of Governance and Global Affairs is there. We do that together. There's influence, of course, from the science faculty. So it needs a multidisciplinary approach. And you have to lead a little bit by example, by stating that this is important and this is the way to go. And I'm convinced that this is a very important contribution to the Netherlands, but also worldwide, in bringing this educational program and research program forward.
Okay, thanks. I think this is a very good bridge to the educational program itself, and also to the person who's responsible for the master, the educational director, and that's Mark Bruinsels. So thanks, Pankras, and welcome to Mark. Yeah, we just heard that there's a lot of things are going on. We need a shift in healthcare thinking from care to health to populations. And so there's a big responsibility on your shoulders. But I know that you have already been working on quite a long time on this master program. So maybe tell us, where did you start building this master program? Where did you start also finding the building blocks for a master program?
Thank you, Professor Bussemaker, and welcome to everybody on the screen and online. And where did we start? Well, when we started in 2016 at the LUMC campus The Hague, we thought, as Pankras just told us, about the way healthcare is moving, is shifting away from a disease orientation towards a population orientation. We start with building an educational program. We started with courses. We started with several courses on population health management. We saw in literature that population health management was an emerging theme, an emerging area which was leading us to a future-proof healthcare. And so we started with courses. And then we saw in the groups, and the first group consisted of 32 people coming from the work field out of the area of The Hague and international. And we saw that there was a twinkling, something happened within the group. Then we thought, okay, if this is the case, why don't we expand and exaggerate? And we made more courses, and we start thinking with more people.
Do you know what made the twinkling in their eyes?
The fact that they could start thinking from the patient and the community perspective, and start building.
They were trained to learn from the system and the medical
and from a disease perspective, or a system perspective, an organizational perspective. They were able to start from the community and the person perspective, and then they start building up the care coordination, or the care, and then the way it should be coordinated for those people and populations. And they saw you needed different approaches for different subpopulations. And then they, is that possible? Can we do that? But the system, okay. And then
Can you give an example? I suppose that many people have an idea about populations. But what kind of populations return in the master program, and how do you make distinctions? Because you cannot distinguish between everyone, because then it's only one individual. So what kind of populations, what kind of level?
There are two ways, and you will learn that within the master. There are two ways of looking at it. First, you can start looking at from a problem perspective. So you start realizing, hey, there is a problem going on in some individuals. Hey, what does that group look like? Oh, that group has those characteristics. That makes it a subpopulation. And starting from that subpopulation and then characteristics like, for example, people with diabetes, but they're from Hindustanic background, which is a large population in The Hague, or people coming from vulnerable families. But then if you look closer, you see that the teenage pregnancies are mostly coming in those vulnerable populations. Then you start identifying a subpopulation by a problem. On the other hand, you can do it geographically. That's what we see as as another approach. So you look at a neighborhood, or you look at a region, or at a city, and then you say, okay, we see specific problems arising in those areas, in those geographical areas.
Yeah.
For example, with low unemployment rates.
Yeah.
Rates in those areas.
So it also makes what, as Pankras argued, why it is an interdisciplinary program, because
Absolutely.
the medical perspective itself, the disease perspective, is important, but it's not the only perspective that and the only knowledge you need to develop.
No, definitely not. We start from a problem, which we try to define also and profoundly also from the medical field and from the medical perspective. But we know and we see that that problem is not only a medical problem. It's often also a social problem, or an economical problem, or a problem which it has other causes. So then you need also other disciplines. For example, the Faculty of Social Science. So a lot of knowledge about behavior and about how it works in raising a child, or in living together in a family, or in a group. What does it mean? So from the social science, you need a lot of expertise as well. On top of that, we see, and that was the twinkling as we talked earlier on, that, oh, is it possible that we make then specific programs for specific groups? Is that then you need to govern that. Then you need to decide, how do we steer that? How do we organize that? What kind of coordination mechanisms are in place? What kind of payment methods are in place? What kind of organizational boundaries do we need then? So Faculty of Global and Governance and Global Affairs,
Public Administration,
they come in, and what we saw, that population health management is really a data-driven approach. So we start also by looking at data. So you need to understand data, to analyze data. So Faculty of Science comes in now, and in that matter, it makes it an interdisciplinary endeavor, which is based in a medical school, which has advantages, because then we can also influence the medical domain, which is a big domain.
And also, which has to change, as we discussed earlier with Pankras Hogendoorn, also has to change their behavior and their policies to move from a medical perspective to a health perspective.
Yeah, to a health perspective.
You told us it's interdisciplinary. All these faculties are coming in, so there's a lot of different knowledge for students. What else makes it special for students in the way? Are they being involved in practice, or are they?
But we have some basic assumptions. We have built a program which is, I think, rather unique, in which we try to combine online education together with on-campus education, and especially in the on-campus education, we have we let them work within practice, in groups, in assignments, within healthcare, within social care, within the society, within the neighborhoods, so that they really experience what is going on within that. So we have a knowledge base, which is being taught online with MOOCs and SPOCs and everything, which is very modern these days, or used to be, not after COVID anymore. But then we have the combination with practical assignments in groups.
You want us to show something of the curriculum?
Well,
I thought.
we can do we can drop one slide if the people can turn on the slide. When you what you see here is the program in which we have combined all the different topics together. In the first year, you see you have or on top of it you see the 4 weeks courses, which are really the first 2 weeks are online. The third week is on campus, which is an intense on campus week from Monday to Friday, from 9 o'clock Monday in the morning till Friday afternoon. And then you have an individual week. During those weeks, you have different assignments and different tests, but we will take it. We take you through the material. Then we have 10 courses in the first year. You see, we start monodisciplinary. Fundamentals is a basic course, and then we start monodisciplinary study design, health and health behavior, and governance. And then we move a little bit to interdisciplinary courses with responsible data, alternative payment models, syndemics, which is really nice. Look it up what it is. Predictive analytics, which is a really tough data course. And then we have 2 final courses in which we have the implementation at stake, panel management implementation, as I just said, in disease or in patient groups or in problem-based, and implementation, putting population health management into action, which is more looking at a geographical area, how you do that. Then in the second year, and we call the second year, and that's another uniqueness of the program, it's very individually made. It's individually tailored program. So you have
can make for a part. You can make your own program.
Yeah.
With building blocks, you
Yeah.
can select from the whole program.
Yeah. So in the second year, you can make your own curriculum based on one of the topics, the specialization that you like, and then you can make your own program. And within that year, you can go abroad using our big international network that we are having as university. You can go do internships. You are doing your research project, and you always end with a thesis. So if you like, you can go for a year abroad. If you like, you can go for 6 months. You can combine it. You can make it a step program. That's up to you. We will guide you through that in the first year. But that's in essence the curriculum.
Yeah. Okay, and what about the students? For whom might this be a relevant program? Or to put it differently, what is your ideal student?
My ideal student is the student who is enthusiastic, who wants to learn, who want to go for it, who want to be part of that movement that has that societal aim of trying to change healthcare in a direction that it will be sustainable in the end, that we diminish health differences which are there right now. So that's the ideal student for me. And then, of course, you have the official admission criteria and stuff like that.
Yeah, of course. But maybe I know, because you organized the summer course before, and my idea was that you also had quite a mix of students and that they also can learn a lot from each other.
Oh, thank you for that. Because one of the unique features will be the mixed classroom. So within the classroom, it will be not only international, but we also like to have a mixed classroom of master students, of PhDs, and of people postgraduate who are working in the work field right now. So there will be an interchange of knowledge and experience from youngsters and experienced people, and that's also a uniqueness,
and that's my own experience. You can learn a lot from each other by learning and doing in the class, whether it's on distance or physically. Yeah. Okay. Maybe we should have a look if there are any questions. We have the Zoom, so everyone can have can ask questions. Is there no? Otherwise, I have another question to you, Mark. What about the labor market perspectives of this master program? Because you will not become a traditional medical doctor.
Nope.
You will not become a traditional sociologist or a public administration student. So what are the prospects of the students?
If you look worldwide now, how the job market for population health management experts is increasing, it's enormous. That is because all the at least the systems in the developed world are now moving. They are really on track. So you see that there are new jobs being created that are the brokers. The people are the brokers between the different systems, but they understand the language of the doctors. They understand the language of the data. They understand the language of social services and how people behave within their own community. And within that combination, you see now a lot of jobs coming. And for example, not only ask me, but also ask Jan Kimper later on, because Philips is on board. And if you see that one of those companies have put population health as one of their strategic aims, then you see that it is emerging also in those commercialized or private companies, next to what governments need to do. What well, as Pankras said, what healthcare organizations and doctors need to do.
Okay, if there are no questions for now, I think you made the perfect bridge, Mark, to the next section of the program, and that's a short lecture by Jan Kimpe, Chief Medical Officer at Philips, and he's really an international healthcare expert. And he is on distance, but he will share some of his experiences, worldwide developments on population health management, and why Philips has put so much effort and innovation into this topic. Jan, are you there?
Yes, I am here.
Right.
And I hope you can hear me well and you can see the screen in the meantime. I am sharing. So if this is okay, I'm going to start.
Go ahead, Jan. Go ahead.
Thank you very much. And I really see this as a privilege to be invited here to give the industry perspective at the start of this master program in Leiden. And as already pointed out by the previous speaker, Philips has become a pure play health technology company. We do not have anything else anymore than healthcare products, healthcare solutions, going from personal health to the in-hospital healthcare solutions. And population health is part of it. One of the companies that we acquired a few years ago was Wellcentive, which is a population health management company in the US. So let us look at this transformation and how it is happening out there in the outside world, and how population health management is going to be part and parcel of this future. We see very profound trends that are shaping the future of healthcare and the future of health technology. So we see these profound trends that are changing the way we have to take care of people going into the future. We have a global resource constraint. We have aging populations, and with that, a rise of chronic and multiple chronic diseases. We see that citizens, as well as citizens before they become ill, and patients when they are sick, they want to be in the driver's seat. They don't want to just get all the messages dumped down on them from the healthcare providers. They want to have a say in their diagnosis, their treatment, and their future. And we see digitalizations as an integral part of all of that. And COVID has really has really almost accelerated this. The move to digital has take an enormous step over the last 15 months. We see, for example, that telehealth solutions and virtual care have gone from a 15 to 20% utilization in the US to more than 60, 70, 80% in 1 year time. Telehealth, virtual care has accelerated enormously because people could not come to the hospitals and still needed treatment and guidance and monitoring. We saw also at our side that innovation had to step up. We had to move more rapidly than before. We have seen this in the vaccine space, where a number of companies developed vaccines in a few months to a year, where it usually would take more than 3, 4, 5 years to do that. We did the same with monitoring devices, with portable ultrasounds, with ventilators, where we improved our ventilators and made new one, including the registration by the respective agencies in weeks, where we usually needed a year or 2 years to do that. We have all seen governments stepping in, taking care of their stockpiling of necessary apparatus and necessary vaccines. And we saw also that our customers, which are usually hospitals or hospital chains, were asking for new business models. So the whole healthcare was already changing and has accelerated the change during the COVID pandemic. We saw that also coming back in the requests of our customers, of the CEOs of big hospital settings. They did not ask anymore so much for a new CT scan or a new monitor with the newest tweaks and the newest features. They asked us much more overarching questions, questions that you as population health management specialists in the future will help us to address. What do I need to stay ahead of government and regulatory shifts? How do I treat my population of patients better, partially remote and partially in the hospital? How can I segment the population I am responsible for in people that can be treated at home and people that have to come to the hospital? How do I manage this aging population and segment it? These are questions that are coming to us, and I am sure that these are questions you are going to address during your training and during your work afterwards. So, which was the position that we as an industry took? We had to move away from being a product selling company, a box selling company, a monitor in a box with a service contract, and then get back to that hospital in 3 years to sell the next monitor in a box with a service contract. We realized pretty early on, 5, 6, 7 years ago, when we were in the transformation as a company, that we had to serve the patient end to end, across or along the healthcare continuum, from helping our consumers live a healthy life, taking the necessary preventive actions if they need to do that because they belong to a risk group, doing a diagnosis first time right, as soon and as fast as possible, give treatment in the minimally invasive way, and then take the person home, the patient home as soon as possible, get them out of the unhealthy and dangerous hospital environment into his home, close to his family, and being monitored and treated at home. That was the first major decision we took. The second thing is to come up with a paradigm that we could relate to our products and solutions. And we have adopted the Quadruple Aim as our general guidelines. To each and every one of the products and solutions that Philips brings to the market, we try to attach KPIs that relate to these 4 goals. Do these products help doctors give a better outcome for their patients? Do these products and solutions improve the patient experience? Do we have less complications? Can we have a better patient experience when the patient has to go to the hospital? Do we increase and improve the staff experience? We all read every day about the enormous burnout rates in healthcare professionals, nurses and doctors. And do we, at the end, help hospital systems reduce their total cost of care? So that was the second thing. Focusing on the health continuum, embracing a paradigm that relates very well to the questions that our customer asks us and that relate to the quadruple aim. The third one is go full speed on digitalization. Digitalization, data sharing, data management, clinical decision support is part of the healthcare system going into the future. If you are not happy with informatic technology, if you are not happy with artificial intelligence, it's better to get out of healthcare because it's all in there for all the doctors, all the nurses, and it's also going to help us segment the population. It's going to help us with clinical decision support. It's going to help us with sharing data across a healthcare system, but also among healthcare systems and even internationally. Then the next step we took is to start working on platforms. We realized pretty soon that dumping data on doctors and dumping data on nurses is not going to move the needle. We also learned from healthcare professionals that simply giving them data would only increase the burnout and increase the stress than making it easier for them to deliver care. So we decided to look at all these data systems as a sort of sources of data in all these records: electronic patient records, lab systems, clinical documents, remote patient monitors, sensors, that are all sources of data. We bring these data in what we call a foundation layer, where we take care of privacy, of authorization. We cure the data so that they can use later on. We can store them if you want, and then we bring them together in intelligence, in workflow improvement solutions, and we try to improve the user experience. That we can do in all the different segments of the hospital and even also out of the hospital. So creating a platform where this huge amounts of data can be curated, stored, privacy and security wise stewardship of these data can help doctors and can help nurses and can help hospital system turn these into tools that they can use for decision making. And finally, and then we are coming really, really close to the population health management, we are willing and looking for ecosystems where we can contribute. So nobody can do it alone anymore. Not a hospital, not a LUMC, not a single health technology provider as ourselves. We have to work in an ecosystem, in a population health management system where all these players are stepping in, sometimes as a leader in an ecosystem, in order to provide an integrated 24/7 care network, and sometimes as a partner in it. So once in a while, you will see Philips leading an ecosystem. Once in a while, you will see a big hospital chain leading an ecosystem and Philips be a partner in that ecosystem. And of course, all these digital solutions, this cloud computing, which I talked about in the previous slide when I talked about platforms, is going to enable all of this. And that is the way we can bring population health management to life. Because if you take that all in, you can very much envision an area of the world, an area of the country where a number of people are living, 500,000, 2 million, even more, that is served by an ecosystem where there's hospitals there, family practitioners, labs, nurses at home, senior nursing facilities that are all connected with the digital tools that we have. and you can really segment your population and give every patient the precision diagnosis and the precision treatment that he deserves. Let me go into two examples and then stop. This is one example we deployed here in the Netherlands, where you see on the top part, the caregiver dashboards that are capturing data from the patient when the patient is still in the hospital, from the monitoring, from sensors, from devices that can be Philips devices, but that do not have to be Philips devices. Reflecting back to the platform, we are able to capture data from all the devices that are out there and manage these data on the platform. When the patient goes back home or to a senior nursing facility, we can, instead of having a monitor, we have sensors and the own patient portable device, can be his smartphone, can be his iPad, and that we can also move to the home with different sensors and with different patient engagement tools on the iPhone or on the iPad. And the second one is, should really resonate with you, and then I stop here, because it is really a population health management tool. It is a platform that we deliver to patients at home, where they can input data, where they can have connected sensors and remote patient monitoring devices that immediately input data into their platform. They can monitor themselves, how they are doing, for example, if they have diabetes or other chronic diseases. But at the same time, these data are streamed seamlessly to the hospital, and they give automatic alerts to the doctors that they have to send a nurse out, or they have to call the patient in, or they can just give a FaceTime advice to the patient in order to improve his general health or his chronic condition. So in summary, we see a transformation in healthcare into a digital healthcare environment, into an environment that is more focused on the population than on the hospital as such. And that transformation is accelerated by COVID. We think that the platform approach and later on an ecosystem will be the future. And we deeply believe that population health management is part of that. And we were talking workforce and we were talking future. I definitely think that some of you will work in our wonderful company when you finish this master, because we will deeply need you. So I'm going to stop sharing, and maybe there is time for questions if there are questions.
Yeah, thank you. Thank you, Jan. Thank you very much. And I think this was a beautiful introduction, also a presentation about what students in population health management might offer to a company and to society at large after their finalizing their degree. Let me start with one question to you. We are talking here today about population health management. There's also a lot of buzz about personalized medicine. And listening to your presentation, I was wondering, is there a difference for you between personalized medicine and population health management? So to what extent should things be personalized to the individual, and to what extent are populations important to take into account?
Thanks for the question. It's a very good question, and like I would understand it, is that population health management is the first step to personalized care. Because if you look at your population that you're responsible for as an ecosystem or as a hospital, part of the population health management is to segment that population. You can look at that population from different viewpoints, from the medical part, from the chronic illness part, from the society part, and segment populations that need a different kind of care. More or less attention, more in the hospital, more remote, depending on all these factors. Then you can take the next step and look at a certain segment of that population and go a little bit deeper to the individual level and then look what an individual patient out of that segment might need for having the best care available for his individual situation. So I see it not as competitive, also not as different, but more or less as sequential.
Yeah,
First,
yeah,
look at your
that's yeah,
population,
yeah.
bring that in your ecosystem, and then look at the individual, what best care that individual can get.
I also started to think about what population health means here because I saw in the chat some comments about digital divide. And you showed us some picture where citizens, people can just arrange their care at home, but they have to fill in a lot of data, and that might be very useful, and they are sent to the hospital. But what with in the Netherlands, we have 2.5 million people with low literacy.
Yeah. Yeah.
So how do we deal with digital divides in this kind of digital developments?
Yeah, you're completely right. I get this question often. 5 years ago, when I came to the company, people asked me, "What if you do not have a computer, or what if you do not have an iPad?" And and that is definitely the case. There are digital natives, and there are people that are not at all in the digital world, that cannot read, that cannot work the apps. I think that is also part of your segmentation. If you segment your population and you take out, for example, the patients with diabetes, there is a certain, now they are all treated more or less, I'm just for the sake of the argument, I'm a little bit provocative, most probably. Now they are all treated in the same way. They all come to the doctor once a month. They bring their test results. They show them to the doctor. They get a new prescription for insulin. They go back home. They wait in waiting rooms, come back the next month, look at that HbA1c again, and all of them have the same kind of care. When you go deeper in that population, there might be people that say, okay, I do not have to go to the doctor each time. I can do that all remote. I have the glucose monitor at home, immediately streams into my app. I can monitor that myself. If I am not okay, I ask for a FaceTime contact with my doctor, and I basically do not go to the hospital anymore. That will free up time at the doctor's office for the people that are not so well versed in the digital world. They can get more, again, personalized diagnosis and treatment and monitoring and coaching, because the doctor has more time for that.
Yeah.
Now
So,
there is a lot
so
of things that need to happen, and reimbursement is one thing. How hospitals are paid and how doctors are paid needs to change in order to make that differentiation in care possible.
that would be my next question, and that might be questions with my background we can talk for hours about, especially because you can't do it on your own. And I think that's exactly one of the issues of the master population health management, and why, as Mark Bruinzels explained to us, you need all the other disciplines, because they also have to change payments models, you have to change policy models, you have to weigh the attitudes. And I really want to stress what you said also about the staff experience and systems of that people have to be engaged. So you also need leadership and valuation systems among healthcare workers. So there's a lot to talk about, and maybe we will find another opportunity, but we don't have time today to do so. For now, Jan, thank you very much for your very valuable contribution and great presentation.
Thank you.
Thanks
Looking
a
forward
lot.
to the next. Thank you.
Okay, and then we continue with Ronne Maihuru. He's a medical specialist working as in one of our partner hospitals, Haga Ziekenhuis in The Hague. And Ronne is one of the leading specialists for internal medicine, and he will show how population health management is influencing his work in daily practices, and also how it should and how we should change healthcare organizations in the future. So, Ronne, the floor is yours.
Yes, Jet, thank you very much for this very nice introduction. And to be honest, I don't feel like I'm a leading internist, but I do feel engaged in this subject. To be honest, I was a little bit hesitant in accepting this presentation because yet I have to admit that the first time I was exposed to the LMC campus and they were talking about population health management, I thought, well, perfect. That's a very fine general practitioners campus where they can do the stuff where I don't have to be bothered with. But luckily, that was a couple of years ago, and over the last years, I've come to work with some very great professionals in that department, and we've started up some very nice projects. And at the moment, we have a PhD candidate who's doing some very excellent stuff on looking at the Hague population, in particular the cardiovascular problems that we often encounter in that city. What I would like to do is take you briefly to into what we are doing at the moment in the Hague Teaching Hospital. And also, while preparing this presentation, I had a look at a wonderful website of the campus, and there were two sentences that got my attention. That you are trained to contribute to a more integrated healthcare system, and to become the broker to improve health and societal outcomes for citizens and patients. I don't know who came up with that term broker, but I don't know, maybe it's a good one, it's not a good one, but I think there is a better one. But it can also be a subject of discussion for the first master's students. So in this program, again, I was thinking, well, this is something for the general practitioners. And what is the role of the different hospitals in this program? What can the hospitals do for this program? And what what can the hospitals learn from the program? Well, what I can tell is that we face a couple of challenges today, a string of challenges that are related to new legislation, the adaptation of it, managing budget while preserving the need for investing in new innovations and infrastructure, and obviously improving the quality of care for our patients, and particularly try to monitor the outcome of what we are doing and whether patients are satisfied or not, and eliminating the need of eliminating the occurrence of incidents, and last but not least, in particular in this period, striving for engaged and healthy employees. Another challenge that we are faced with, but also where other healthcare professionals are faced with, are two things. The number of elderly people that are increasing over the following decades. What we will expect is to see is a 25% of people who are older than 65. What we have seen over the last years is a rapidly increase in healthcare expenditure, and I think the combination of the two will definitely have a serious effect on what we are doing in hospitals and what other healthcare professionals are doing. So we have to take that into account, because also the increase in number of elderly will also have a result on the number of people who are working and who will have to take care of the elderly, and who will have to take care of social costs such as healthcare. The The first start of what we were confronted with is in 2018. That's an agreement, the Administrative Framework Agreement, Specialist Medical Care, that was made by the ministry together with relevant healthcare parties in the Netherlands, with the aim to use the following 3 years until 2022 to look to preserve the access of good quality care at the right place and do that at the right time against the right price. Well, that's easily said than done. And what's relevant in this agreement is that we should strive to be more outcome-based rather than think in terms of interventions. That was the first part of the agreement, and the second part of the agreement was a financial one, which was quite disappointing and enormous challenging for hospitals, because what you see here in this slide is that we believe that on a yearly basis 1.2% of costs will be made additionally, and that in the agreement it was settled that the maximum national growth was set at 1.7% over the period that we that the agreement was set on. On the right side, you see the figure where you see the differences. An allowed 1.7% growth, whereas the growth that is expected to be 4.9%. That's tough to hear, that you have to treat patients, that you're not allowed to grow, and that we had the feeling that we had to close doors for certain kind of patients, but obviously that is not something we can do and we're not supposed to do. Please see here that we looked at the situation in The Hague, and where we where the expected regional growth of care without intervention would be 6.2%. So that is even more than what nationally accepted. This, with an accepted growth in our area of 1.7%, is that we had to absorb, we have to absorb 4.5% of demographic growth under constant budget. The demand for care in The Hague is growing, and that's what we see here, and we expect that to be for the following years to come as well. And we need to tackle this challenge, because it is a difficult one, but we can't do it alone, and we have to do that in collaboration with different partners in the field, and we have to organize it differently in an innovative way. And obviously, it all starts with ourselves. So I'm going to show you some slides of a program that we are running right now in our hospital, just to give you a feeling of what we are doing to take care of our patients so that they can be treated the best way and at the right place. Because of the challenge that we have, the Hague Hospital decided to start a transition program that is named the Hague Cares Nearby, in which we are running several projects. The projects within the hospital that we do in collaboration with healthcare providers in the region, such as general practitioners, nursing homes, and fellow hospitals. All projects are summarized or categorized in 5 themes. The first one is optimization of care process. So how can we improve our internal processes so that our patients go through the care process via a more efficient way, and while maintaining and improving the quality of care for these patients. The second theme is shared decision making. Obviously, it's something that has been talked about a lot. Patients, well-informed patients, that talk and decide along in the choice of treatments that we make or the treatments that we don't start. Cooperation between various healthcare professionals is the third team. How can we improve the cooperation between general practitioner and the medical specialists in our hospital? And how can we make the expertise of the medical specialist more available to the general practitioner? Thinking of, for example, by digital consultation and direct access to diagnostics for the general practitioner. And I think the previous speaker just demonstrated some very nice examples of how you could use that. The fourth theme is cooperation with nursing and care homes. We try to intensify the collaboration with nursing and care homes in the region to further improve inflow and outflow of our patients. In this way, all patients receive the best care in the right place again. And the fifth term is care at home, how to use latest technological developments for chronic patients, and how can we keep an eye on patients in their own home and give them the medication that they need in order to stay healthy or not come back to the hospital. So these are two or three examples of some projects we have in Hagen Teaching Hospital. My apologies, but some of the words are in Dutch. What you see on the left is a project that is called the triage of referrals, referrals from general practitioners to the medical specialist. What you see in the middle is a teleconsult, which is nothing more than a digital consultation of a medical specialist by a general practitioner. And on the right, you see a make-I consultant or viewing consultant, and that can be that the medical specialist is asked to come by to the office of the general practitioner or have or look at the electronic patient dossier as an additional treating physician. Two, I would like to show. This maybe I can come to my conclusion after that. Yes. What you see here is that we started the triage of referrals in 2019. What you see here, different colors of lines resembling the different disciplines in the hospital. And what you see is that there is a number of referrals that are not taken up anymore and not seen in a hospital. The patients are referred back to the general practitioners while they are not seen, but the general practitioners are instructed and informed on what they can do by telephone and by a letter. The second one is the number of digital consultation by general practitioners by general practitioners of our medical specialists, and this is something that I'm very enthusiastic about, because what we see here is that there is an increase in number of digital consultations, which largely also results in less unnecessary referrals to our hospital. Let me end by, if the chairman allows me, with two slides. I think the program that we are running is an interesting one, but it is an internal one, and we collaborate with different parties in the field. But I think it will not be enough to tackle the phases that the hospitals encounter and also the other healthcare parties. What we are doing right now, does this help to improve the patient experience and outcome? Will these patients not be referred to other centers? What is the role of the doctors within this new model that we are using? Well, I'm happy to announce that we have a very nice collaboration with LUMC Campus HADOX, which is the main organization for general practitioners in The Hague, our hospital, and HMC, where we have three very talented PhD candidates who are looking at these questions right now. So let me end by and with this slide, I think it is time for an integrated healthcare system. We cannot do it alone as a hospital if we want to tackle this increase in demand for healthcare. And particularly the rising healthcare costs, fragmented healthcare is something that we need to discuss and need to tackle. And again, hospitals need to be part of this integrated system. So, and I think this subject that is a very important part of the master program, the master that is started here in LMC campus. And I think I've read the website and what you're planning to do, and I'm very enthusiastic, and I'm very curious what comes out of it in the next 2 years. So let me end by congratulate the LMC campus, the dean, but last but not least, Mark as program director. I think that he paid a lot of attention to have this master started. So, but I think he did a great job, and I'm very excited to be part of this journey.
Thanks a lot, Ronne, and it's very good to see how the connection between an educational program and a master's so is so closely linked to the practice of a medical specialist in a hospital in The Hague.
Yeah.
And I was thinking, listening to you, you want to try to relate what's going on within the hospital to the outside world and all the other professionals. And Jan was giving the network healthcare system. And I think that's what you are trying to do, to shift from a building that's with closed doors to become part of a network healthcare organization with more attention to prevention and also other ways to the of talking to patients, digitalization, etc.
Yeah.
So great. I'm looking. There's time for one question? No. So Ronne, let me ask you. What do you imagine there is a graduation from the master population health management, and then some of the students, they want to apply for a job in your hospital.
Yeah.
What is important for you that they that the knowledge or skills they will have after the master to help you with your mission in your hospital?
Yeah, well, I think that I lack the knowledge on how to tackle this. There are some serious questions that need to be answered if you want to change this healthcare system. And obviously, we need people with knowledge, with expertise, and graduated students who have specialized in this particular field. So I'm. So while I expressed my positive about the program, I also expect in 2 years that you come up with that the master program comes up with a solution of the problems we save. So that's I think Mark can handle that. But I seriously believe that we need somebody who knows how to integrate all these very difficult healthcare fragments.
So you have high expectations.
Oh, obviously, yes.
Of the master of Mark, of all the students coming in.
Yes.
And then we will try to solve the problems in healthcare that worldwide people are working on. And then the Haga ziekenhuis, together with the campus, will give the example how we have to do it. That's the challenge for the future.
Okay,
Thank you very much,
we can put it in an agreement.
And then I would like to invite Matthijs Numans to take a seat. Matthijs Numans is Professor of General Practice at LUMC, and he's also the director of the LUMC campus in The Hague. We heard a lot of knowledge, of content already about the master program, but maybe you can share some information with us about the way the population health master is embedded in the campus, both from the perspective of content and from the perspective of organization.
Yes. Thank you. Yeah, well, LUMC Campus The Hague is originally established by LUMC and the community of The Hague and the hospitals and the primary care organizations in The Hague to improve academic cooperation. We are there about 5 years now, and I think we established a population health living lab there too, which consists of all disciplines and all people who are involved with healthcare and population health developments in the area. This is
and I can emphasize that being one of the professors also working at the campus, so it's flourishing, it's growing, and there are a lot of activities going on.
Yeah, originally it's from the position of the LUMC, it's one of the ways to increase their societal impact in the region of The Hague in the health
maybe
domain.
you can also tell something about the way it's embedded, because the campus is also part of the buildings of Leiden University in The Hague.
Yeah, well, actually, LUMC is the medical faculty of Leiden University, and that's why we are in the building of LUMC is part of the building Campus The Hague of University of Leiden. So all other disciplines there are involved in the cooperation with us too, and actually we're one of the smallest parts of the campus there now.
Yeah, I myself am also affiliated with the Faculty of Governance and Global Affairs, and the whole faculty is embedded in The Hague.
Yeah, that's the only faculty that's wholly embedded in the.
So there is a close collaboration between the faculties in The Hague and the faculties in Leiden, and also people coming in and out and teaching within the master program.
Yeah, one of the living lab assets now is that we have 3. Apart from you, there are 2 other positions for professors with other faculties, like the behavioral interventions and the data science input.
That also brings me to my next question, because Mark Bruinschels told us a lot about the interdisciplinary character of the master program, but there's also a link with research. So the stimulation program and living lab, that's more about research, or it's about research and education?
Well, we begin with education. That's been our policy for the past 5 years already. Involve the professionals in the field with our philosophy on population health management, and this is what was the origin of the master now. So it begins with education, and now we have a portfolio of about more than 30 PhD students from all kinds of disciplines. There are primary care physicians, secondary care physicians, but there are also many people who are health involved students already, and there are people from Faculty of Governance and Global Affairs, psychologists involved in PhD trajectories in our campus area, and they're all involved in interdisciplinary cooperation.
So it all starts with education, but finally education and research and societal impact, I would add, are closely related.
Most of the problems are generated or yielded from the field where we work. So from the Hague area, where the health inequities are big, and where the health problems are very interesting to educate, but also to train our physicians, especially our primary care physicians, which I am, in the field of the Hague with the huge differences, and to add evidence on how to attack this.
And also to try to improve society and health disparities, to solve health disparities.
And that's the societal impact we try to have.
So I asked him in the beginning, the Dean Pancras Hogendoorn, when he would be satisfied within 5 years.
Yeah.
So for you, the same question. What do you expect from the master? And when are you satisfied, let's say in 5 years' time?
Yeah, I think I would be very satisfied if we have indeed a flourishing interdisciplinary educational and research community in The Hague on the field of population health and primary care, to improve and to add on the evidence how how to change the challenges in healthcare.
Yeah. And also, what makes for you this special? What is the distinction with other programs from other universities
Yeah,
or
well,
university medical centers?
the huge difference between our program and other programs is that we have a rather heavy clinical input in the program. So there's a medical part is bigger than in other management oriented and
Yeah.
closely only epidemiology oriented programs. So especially, it's not only that we have the psychologists and the governance of global affairs and the data scientists, but also the medical part is rather strongly developed.
And you all want to train them also to collaborate and to learn from each other,
Yeah, that's
having this kind
that's
of
the essence of
mixed
our
classroom.
that's
Yeah.
the essence. And so
Okay.
this will help us to improve healthcare and
Yeah.
help us to improve health. Yeah.
I think we are coming to the final launch of the master. I don't see very urgent questions. No, am I missing something? No. So let's go to the closing and also to the celebration. And please stay here, Matthijs, because this is the announcement of a very joyful moment that we would like to share with everybody. First, thanks for all the people being involved in the master and the organization of the launch. And I think Mark Bruinzels, he's already mentioned a couple of times, as educational director, played a very important role. But also Matthijs, you as the director of the campus, Pancras Hogendoorn, the dean, but also all the others. So thanks again also to Jan Kimpen and to Ronne Maihutu, who also told us very clear what the impact might be of such a master. So we wish all the people of the Faculty of Masters and Population Health Management in particular good luck. And after this moment, there will be a short movie about the program. So everyone who wants to know more, please keep online and you can stay tuned and you can watch the video. And I hope that everybody from bachelor students to professional master students will sign up for the program. So maybe see you somewhere around on our beautiful campus in the center of The Hague. And now, Matthijs, I would like to invite you to push the button to celebrate this very special moment.
Yeah, well, this simple push on
this we button. Don't do it together because that's not corona proof. So you do it, and I am gonna. I watch it.
Okay,
I'm here.
So with a simple push on the button, we'll start this magnificent program.
Do you want to create a sustainable healthcare system and become a catalyst for change? Join the new interdisciplinary master program, Population Health Management. The healthcare system of today faces many challenges and opportunities, such as an aging population with multimorbidity, increasing socio-economic health inequalities, and emerging technological innovations. The main objective of this master program is to create new strategies that integrate medical and social care, redesigning the healthcare system. The master program focuses on the full spectrum of care, from prevention to specialist care, and consists of an interdisciplinary approach aimed at different population groups. You will learn to integrate medicine, data, governance and behavior to design and implement sustainable strategies. During the 2-year master program, you will be offered a series of integrated courses and projects. The first year consists of a blended program with online courses and intensive on-campus weeks. The second year is a flexible, tailor-made program with your specialization and a research thesis. You might carry out research projects for national and international organizations. After completion of this program, you are an academic strategic partner to various organizations, supporting new strategies to stimulate sustainable healthcare. You will be able to analyze health problems from various perspectives, design solutions for population groups, and be able to assess and communicate the value of these new strategies to various stakeholders. We are looking for excellent bachelor students with a solid background in medicine or health sciences. And given the data-driven nature of population health management, affinity with quantitative methods is needed. You are open-minded, innovative, and have a strong will to improve the healthcare system. Do you want to become an academic strategic partner in the field of population health management? And do you have the right qualifications and skills? Then visit our website for more details about our program. And I hope I'll meet you in The Hague.